right, welcome everyone to our third week of Geriatric Bootcamp. Today we're going to be talking about delirium and acute brain failure, as well as the long-term consequences associated with that. We have the esteemed Dr. Jim Rudolph here, who's going to be talking about the topic for today. But before we get into that, we just have a few housekeeping items we'd like to get through before we get into today's topic. So if you're not familiar with who we are the iPro QIN-QIO. iPro holds the federally funded Medicare QIO contract for the regions shown here. iPro specifically helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are 3 organizations under the iPro QIN-QIO banner. So if anyone asks if you know who iPro is or if you're working with iPro, you say yes. At this point, I'd like to pass it to Mary Ellen to give us a COVID-19 update with everything that's been going on.
Sure thing. Thanks, Josh. So as people probably know, hospitalizations are on the rise. As of the 12th of August, we've seen an increase of 21.6% in COVID hospitalizations. Deaths have also increased from the prior reporting week. As of the 19th, we were at a 21.4% increase. The latest variant, EG.5, continues to be the dominant strain for causing these infections that we're seeing at 20.6. It kind of leaves the pack. But I just wanted to draw your attention to what's been in the news lately, which is a new variant being tracked by CDC, which is the BA.2.86. It has a large number of genetic differences from the previous versions of SARS-CoV-2, but it is still part of the Omicron lineage. So that more testing needs to be done to know the real-world impact on immunity. But CDC does have a really nice site, Respiratory Virus Updates, which provides weekly updates of what the variants are and provides a risk assessment summary that you can read about the latest variants. So more to come, I'm sure, but I will pop that link in the chat for people to review. And that's it. Thanks, Josh.
Perfect. Thanks so much, Mary Ellen. At this point, I'd like to pass it over to Jim Rudolph, who's going to get started with our topic. Jim, over to you.
I'm unmuted. All right. Thanks, everyone. I'm Jim Rudolph. I'm a geriatrician palliative care physician. I'm based out of Providence, Rhode Island. Next slide, please. Really what I want to do today is to talk with you about delirium and the associated consequences, particularly in skilled nursing. I've really tried to keep that focus in the skilled nursing space. Skilled nursing presents some real acute some challenges for delirium, in that many people come to skilled nursing through the hospital where they acquire the delirium, and then skilled nursing gets to deal with the long-term consequences of it. I'll talk about management. I'll also talk about some of the specific things in skilled nursing that are unique to management. Next slide, Josh. So I am primarily a researcher, and I've got grants funded by all sorts of organizations. None of them really pertain to delirium necessarily. I do work with the American Delirium Society and was the recent chair of the conference held in Providence, Rhode Island, or co-chair of the conference held in Providence, Rhode Island. But like a lot of nonprofits, I do a lot of work, but don't get any pay for it. So the final part is that any discussion we have of drugs today is off-label, because no drugs are approved for delirium. Next slide, Josh. All right. What makes delirium different? And so delirium is an acute change. It's a very rapid change in cognitive function. Delirium differs than dementia, where dementia has this memory focus and this long-term change. Delirium is very rapid and acute, and the primary cognitive deficit is in attention. So that people really struggle to focus their mental energy. They struggle to access information in their brain that should be accessible, and really struggle. I really believe that attention is a rudimentary cognitive process that's necessary to take in new information into our brain, process that information and react to that information. So if you were a squirrel running across the road, you look and you see the car, you have to react to that information to survive. Delirium is that same component. You take in information, whether it's auditory or visual or other sensory, and you react to that information. That's attention, sorry. And then delirium is when that attention component fails. Really a rudimentary thing. Because attention is sort of this quarterback of recruiting other cognitive domains, many other cognitive domain or testing of other cognitive domains is inherently messed up when inattention is present. And then also combined with that inattention is often this reduced levels of awareness. So hypoactive states where people just can't be either aroused or sufficiently aroused to engage with their environment. The hyperactive state where we rarely miss a hyperactive delirious patient, and then mixed where there's both elements of hypo and hyperactivity. Next slide. Over the years, the literature has called delirium by many different names: acute confusional state, sundowning, poor historian. My favorite is the wild man syndrome, where the clinician gets the call that you better get over here. Your patient's a wild man. A metabolic encephalopathy is the billable diagnosis for delirium. Next slide. It's incredibly common in older people. So, think of the skilled nursing setting, and you look in that and you go, only 7 to 24% of people come in with delirium. That's not terrible relative to a medical ward or an ICU. But remember, those people are coming through the hospital, and so their delirium has had time to develop and mature in those other settings. It's interesting that even in elective cataract surgery, about 4% of people who have elective cataract surgery will meet criteria for delirium the following day. Next slide, Josh. Huge morbidity and mortality. And this is a combination of the severity of delirium, what it does to our brain, and the inability. It sets people on a course that is just not a positive rehabilitation course. So there's a tremendous risk of functional decline in people who develop delirium. They just can't, they can't mentally process the information they need to engage in rehab to get that therapy they need to go on. There's large amounts of nosocomial infections in terms of aspiration pneumonias, catheter-associated urinary tract infections, things like that we do to people who are intermittently up and awake and then relatively sedated or confused. Increased risk of conversion to long-term nursing home placement. Multiple studies have borne out now that delirium is associated with residual cognitive decline. That means you take a person with cognitive decline, superimpose delirium on that person, and they're probably not getting back to their previous baseline, which means we've just made their cognitive decline a whole lot worse. And the risk of death continues on for years afterwards. Delirium is a bad prognostic sign. Next slide, please. It is costly in terms of staff time, because these patients just can't be left alone a lot of times. And they require both our physical presence, but also our mental presence. Patients with delirium tend to stay both in hospital and in skilled nursing for longer time periods. The studies that have looked at this found that a patient with delirium will accrue $16,000 to $64,000 in additional medical costs over the next year. That's additional above what they were an age and gender and comorbidity match control would do. And then when you sum that up, we're looking at about $100 billion per year. Some of that is in hospital costs. A lot is in rehabilitation costs. Next slide, please. We also need to recognize that delirium affects us as providers. It takes more time. It takes more mental energy. It burns us out emotionally. When you look at resident on staff violence, delirium is going to be a key player in who gets hit amongst your staff. These patients take longer to hand off. They take longer to transition out from the SNF back to home or to skilled nursing, and that all imposes difficult decisions. These patients with delirium, their brain is fundamentally failed. Josh, next slide, please. You can name your patient safety outcome, and I can probably draw a link to delirium with it. Certainly falls, and you know, it's a circular thing. I don't know whether delirium is the cause of falls or that people who fall get delirious. And it's really hard to do studies of that, but there's a high relationship between those. These patients are more likely to die, to be readmitted, to develop pressure ulcers, to wind up on antipsychotics, to develop aspiration pneumonias. Is restraints on there? Restraints should probably be on there as well. Delirium is associated with all. It turns out this brain thing, it's really important. Next slide, Josh. All right, here's our model. We take a predisposed patient, and a patient may be predisposed because they have existing cognitive impairments, because they have sensory impairments, because they have a lot of comorbidities, because they're on a lot of medications. This patient is predisposed to that. We impose an insult. Oh, go ahead, Josh. We impose an insult, which an insult can be anything from a room change to a new medication, to an acute medical illness, to a new infection, any of those, to a change in their sensory perception. All of that are insults to this predisposed patient, and their brain reacts differently than yours and mine would. All right, next slide, please, Josh. If you take anything away from this, think that a delirium is acute brain failure. Right, we don't mess around when someone's in acute heart failure. We find a way to assess them, manage that heart failure so that they're more comfortable. Delirium, we don't do so well when someone's brain fails. We just don't know how to engage and interact. Next slide, please, Josh. It's important that I mentioned this when we were talking about drugs early on, but the treatment of delirium is to identify and treat the underlying causes. There are no magic pills for delirium, and I will state very clearly that antipsychotics, including the atypical antipsychotics, are not approved for delirium and do not actually treat the delirium. You can't tell me that those medications somehow improve someone's attentional abilities. They just don't work that way. And certainly benzodiazepines are considered deliriogenic. And if someone wants to engage in a debate about anticholinergic medications, I'm happy to do that offline, but they are also likely deliriogenic. Next slide, please. So as we're going through and thinking about, hey, we have to think about the underlying causes for delirium when a patient has delirium. We first turn our attention to, we've created a checklist. There's a number of mnemonics out there. This one happens to spell out delirium, so it's my preferred one because it's easier to remember for me. But we should be thinking about things in our mind. Drugs, particularly new drugs, that have cognitive activity, and lots of medications have cognitive activity that we don't think about. If the medication causes sleepiness or has actions inside the brain, and I'm talking gabapentin, selective serotonin reuptake inhibitors, those are new changes to someone's brain, and can be deliriogenic in someone who's predisposed to that. Electrolyte abnormalities, think of hyponatremia, renal failure could fit in there as well. Lack of sensory input is sufficient to cause delirium. And there is this syndrome when skilled nursing patients go back to the hospital, sometimes that change is sufficient, the environmental change is sufficient to precipitate a delirium. And largely we believe that it's just a new environment and the brain is overwhelmed, so it shuts down that rudimentary attention process. Infection can do this, retention of urine or feces can do it, Surgery is probably the best model to study delirium, and the more intense the surgery, the more likely that delirium will develop after that surgery. Underdosing of prescriptions, and this is one that really pertains to the SNF population, right? When you get a partial list of medications that they were started on in the hospital, and it may not include their home medications, right? Because if someone's going to surgery, they pair off a lot of the medications, which can be delayed during that surgical time. And people can withdraw from a lot of medications that we don't always think about. I mentioned SSRI, certainly potentially a cause of delirium, but a lack of an SSRI actually can precipitate a delirium. If those medications have cognitive activity and they were in a steady state beforehand, I'd be hesitant, and they're no longer on. Thinking about reinstituting some of those meds may be necessary. The exception here again, benzodiazepines and anticholinergic medications are most likely deliriogenic in nearly all conditions. Next slide. All right, a couple foci for the skilled nursing facility. Next slide. All right, skilled nursing has unique features in the population. It's in the population who go to skilled nursing is inherently functionally declined and predisposed to delirium, because if they weren't functionally impaired, they would go home. And so this population coming into skilled nursing is highly vulnerable to the environmental changes, to the lack of sensory input, to medication changes. All of those things are very put the population at high risk for delirium. Second part, I've already mentioned this and I want to highlight it again, is the pre-existing delirium. And skilled nursing tends to be the recipient of a lot of hospitalized patients who develop delirium and can then no longer go home. I don't think I need to tell people on this call about the inadequate information that comes to people. It's funny how delirium, just like pressure ulcers, developed somewhere in the ambulance between the hospital and the skilled nursing facility. There's no mention of the delirium in the notes or discharge summary, but the patient comes into the facility with inadequate information and floridly delirious. There are less intense services in the skilled nursing environment than there are in the hospital environment. So the idea of having a one-to-one patient safety attendant would be way more limited in the skilled nursing setting than it would be in the hospital setting. And those patient care attendants can really be lifesavers for a lot of people with delirium to get them through, particularly without medication or restraints. And then I did mention the environmental change as well is something that happens in that skilled nursing environment. Next slide. Delirium is equally as bad when people go to skilled nursing. Those people who come in with delirium are more likely to have complications, lower functional recovery, increased likelihood of rehospitalization, more likely to have a transition to long-term care, and then increased 6-month mortality. Look at that, 25%. You know, that's a huge mortality when they present to you. That's really powerful knowledge as they present. Next slide, please. Your work in skilled nursing can make all the difference. And so this was a study that looked at delirium on admission, and if it was rapidly resolved, those patients went on to do okay functionally. If it took longer than 2 weeks to resolve that delirium, those patients didn't do as well. If it recurred, which is the third line, then those patients did a little less well. And then if it never resolved during that time, the less than half those patients went on to recover fully from that episode. So early intervention to identify delirium, develop a care plan around delirium, and treat delirium, really, really critical. Next slide, please. My work here today is, you can all tell that I'm speaking very rapidly because we only have 30 minutes, but there's a huge knowledge gap in delirium. And this slide is based off of the work of Mindy Stice, who's a good colleague of mine, who really showed that staff in both nursing homes and acute care really struggle to identify delirium and to differentiate it from dementia. You can look at that delirium superimposed on dementia at the bottom, and we have a huge knowledge gap that has to be overcome. And I'm fearful a lot of times that because we have that knowledge gap is the reason that there's such this pressure to prescribe medications which aren't necessarily helpful. Next slide. All right, so I'm gonna open it up here. First, I'd love to take any questions. Second, I do have a case that's ready to go, and it's however we want to spend the remaining 7 minutes that we have. Holy cow, this is quick.
Yeah. All right. So I'll just emphasize everyone here on the call, if you want to come off mute or put your question into chat for Jim, that would be much appreciated. And while we give people some time to put some stuff into chat, Jim, why don't we start with the case and then see what happens after that?
That's fine. And so as I was thinking about the case, I really wanted to put myself in the provider's shoes. And so thinking about my experiences in skilled nursing, where you're getting a patient who was essentially a surgical train wreck with a abdominal surgery and a lengthy recovery following that surgery, his family is engaged but not present for this transfer, and the hospital just bombed on the transfer. And so the patient arrives late. He's hungry, and of course you get incomplete medication history and a discharge summary which really doesn't mention anything about the delirium or the surgical course, and nothing on the discharge paperwork to recommend a dietary order. And his attention right now, he's hangry. He's fixated on eating, and everyone's desperately trying to get in touch with someone. And so the question that I'll throw out there is, what's going through your mind?
All right, everyone. I'm sure you've had similar cases like this in the nursing homes, unfortunately. But if you want to respond to this case, we'd appreciate you guys to either jump off mute or put into chat. We'd love to hear, and really are interested to hear your perspective and your thought process on this.
So I can start while we get some chat. So I would wonder, what was the nurse to nurse communication? And oftentimes they actually get more information than we get in the documentation. So assuming that there was a nurse to nurse communication from the hospital nurse to the SNF nurse, I might rely on that until we communicate directly with the discharging providers at the hospital, and see if we can get the information that's missing, at least initially. And of course, the nurses on the unit, that they're tasked with figuring out exactly what's going on with him currently, which makes it very difficult for them, especially if he's not in a good mindset to provide information, whether he can or can't. So it's very difficult for the nurses, and of course they're only communicating with me oftentimes over the phone. So we're all like, it's just a bloody mess. So I wouldn't want to be the nurse that's admitting this person.
I would concur with that, right? And my, as I was thinking about this, we have very little information. And so what I'd like to highlight is the first is someone's got to go talk with the person, with the patient, with Mr. S, because we have to figure out, is this hunger, right? Is he really just hungry, or is there an underlying cognitive deficit? And then we can start, we need to gather more information. And yes, if we have access to those nurses in the or that communication that happened previously, that'd be great. We all know that always doesn't work out and things like that. So I like Lisa's comment about getting them to feel calmer, feel safe, and listened to. And Lisa's already starting to go through her differential and her assessment, which is great, right? Could a Snickers bar really solve this problem? And I think I'd rather give a Snickers bar a shot than I would a medication at this point. So going and talking with him about what he had for breakfast, helping to indulge that food, because at the very least, a turkey sandwich might not be a bad intervention in this case if he was previously eating. So
So
yeah.
Shiloh says, what can we provide for him to eat? Is he dehydrated? Can we get a set of vitals on him? Is administration going and speaking with him? If he's requesting food, it's his right to eat. Are we contacting the family to see what he was eating in the hospital?
Great. And Shiloh brings up a great point. In this hubbub of getting a person out of the hospital, remember, it's chaotic on the hospital side, but we also know that he came over a couple hours late, right? And so he may not have had something to eat or drink for 4 hours now, which in you and I, we can probably get by with that. Although I'm really thirsty right now. He, who's just had abdominal surgery and fluid shifts, may be a little bit more fluid dependent than either of us. And so focusing in, going and talking to him, getting assessment from him of what's needed, and then doing some of that frontline stuff to connect with him, as Lisa mentioned and Stephanie mentioned, and then really understand what some of his early needs are. It can be critical.
Well, that looks like all we have in chat so far. Linda actually just chimes in, reaching out to a social worker too, if there's any social work at the hospital that might be able to assist. Yep,
I would agree with that. Gathering more information, right? So really awesome.
Oh,
and Patricia's going to start a relationship with the family. I agree with that one too.
Yeah, get them on your side rather than have them complain to DPH. So it looks like we're close to the time. I know there's a couple of pearls of practice you wanted to go through, Jim.
Yeah, just quickly, when people come to you, again, if we can improve that, if they are delirious and we can improve that delirium, that is so critical for the rest of their lives. And I again, that would be my second point to impress is everyone can make a difference in delirium. It doesn't take a physician to give someone food and water, right? Those are really important things. Empower your staff to screen and treat. If they do trigger the minimum data set, really take that seriously with a written care plan and then communication of that care plan across your system. And then think in parallel, right? The delirium often has multiple causes. So just because we gave him food and drink doesn't mean he isn't having some other issue that's can be contributing to this. So thank you all very much for participating with me in this. I apologize that it was so short. And if anyone wants to reach out and discuss more, go ahead and shoot me an email.
Perfect. So thanks so much, Jim. I'm going to leave up this screen just for folks to jot down your email. I'll also be providing a copy of the slides for people to have at their fingertips as well. And at this point, I'd also like to share our contact information. If you have any questions or need any additional assistance with your quality improvement initiatives, you can reach out to any one of us. We're more than happy to assist you with anything that you might be working on. So that'll be it for today's session. If you thought that today's session was beneficial and useful of your time, it does mean a lot for you to drop a quick comment into chat that you thought so. It does help us inform our future content, and would I'm sure Jim would appreciate the feedback as well. This session was recorded today, so if you know anyone who missed out today that would benefit from seeing the session, we are playing a live replay of this session again tomorrow at 3:30, so I encourage them to join us for that session. And then we also have our infection control IP3 office hours this Thursday at 11, so I encourage you all to participate in that session if you aren't already planning to. All right, well, that'll be it. Thank you so much for joining, everyone. I hope you have a great day. Thank you so much.